Alrighty, everybody. Today's topic is common procedures. This is going to be kind of short and sweet in comparison to some of the other lectures because a lot of this you're going to cover more in your actual lab. Okay, so before you do a procedure on anybody, you got to make sure that you have informed consent. In some instances, informed consent is implied, and that would be like somebody comes into the ER unconscious or something, and they need to have, I don't know, something drastic done. Then it's just implied. You don't obviously have to get it before you do anything. But in most instances, you need to go through this whole process. And the important thing is that it's a shared, it's a decision that's made between you and the patient, and that the patient is an active participant in this process. And they need to have sufficient information to make an informed decision. So you have to actually go through like risks and benefits and such as well. And then it also needs to be obtained by somebody who's actually involved in the patient's care. So somebody that is actually doing something there. Details to include the diagnosis that you're treating it for, the nature and purpose of the procedure, risks and benefits, like alternatives to doing the procedure, and then the risks and benefits of those alternatives. And then lastly, the risks and benefits of not doing anything. And it's also important to note that you get informed consent before the patient takes pain medication or anesthesia or anything like that. It's void if the patient has been altered at any time. So when you're doing your procedures, infection prevention is paramount. Okay, so universal precautions, and we've talked about this before. These are the things that you do with every patient every time you touch a patient. Okay, so these universal precautions, you're supposed to use, at least gloves every time there could be exposure to blood and other body fluids and any type of skin tissue. Okay, so obviously if you're suturing or doing an IV, you need to wear gloves. Universal precautions don't apply to some of these other bodily fluids. And really it's just to say you need to use extra protection when you're dealing with those as well. Okay, so asepsis and aseptic technique. Most of the time, the facility you work with or the whoever you work for will have policies based off of what this actually means. And so I've worked for a couple of different hospital systems, and it's always kind of outlined what I'm supposed to do for this. The biggest thing that I want to highlight is hand washing, gloves, and maintaining clean equipment. And so hand washing, it seems dumb, but it's the biggest thing you can do to help protect your patients. And you need to do it correctly. Okay, so in nursing school and in my DNP program, we actually had to like demonstrate this. And so if you just start watching either yourself wash your hands or other people wash your hands, you'll notice people kind of go like this and then maybe like this and then they're done. Okay, but what they didn't clean at all is their thumbs, fingernails, and oftentimes in between their hands. And so we did this thing where they squirted the stuff on our hands, and you had to wash your hands really well, and then they put black light over it. And unless you were super conscious of those various things, everybody missed their thumbs and their fingernails. So when I don't know if you guys have had to go through this at all, but important to note that you go like you're all the way around your thumb on both sides, and then put one hand into kind of a ball like this, and then rub it into the soap there. And then that will help clean both of those. And so it really takes like a good 30 seconds in order to truly get your hands clean enough for these procedures. Okay, maintaining sterility. Box 6-2 will go through the proper technique for opening and donning sterile gloves. The more you do it, the better you'll get at it. We utilize sterile drapes a lot to help with the sterile field, and figure 6-3 goes through that as well. And then just some basic principles of sterility. So once you set up your sterile field, you need to never leave it. You can't turn your back. You need to make sure that it remains sterile, because if you're not around, you don't know if anything touched it, obviously. Most sterile fields, it's considered that the inside of the package is sterile, but then there's a 2-inch border around the edge that is considered non-sterile. And that's where you can touch if you need to move it before you have your sterile gloves on. Okay, and you also don't want to reach across the sterile field, because if I'm reaching all the way across to get something, I could touch something and not even realize it. And the biggest part about sterility is if you see a break in sterility, speak up. You need to say something. And any good provider, healthcare, anybody should acknowledge that and say, oh, okay, let's backtrack and let's do this again. But thankfully, there's not a ton of procedures that you have to have true, like, complete sterility for. Okay. And then once you get sterile, you have to do whatever it takes to stay sterile if you have some time. So I worked advanced heart failure, and we had people with mechanical hearts. And we'll talk about that a little bit more later, not because it's super relevant, but I just think it's fun. And they have what's called a drive line that comes out through their stomach. And it's essentially just a power cord that you have this like kind of gnarly dressing around the edge of it. And this guy's was infected. And so I had to do a pretty lengthy dressing change on him that had to be sterile. And it involved like soaking these gauze and wrapping it around it and such. And then I had to wait for 10 minutes and then take it all off and put the dressing back on. But in that time, I couldn't take off my gloves. I needed to maintain sterility. And this patient was in the hospital for quite a long time, so he got to know us pretty well. And he found out that I hate scary movies. And so he put like, I don't know, some ridiculously horrifying movie on in the background when he knew I was going to be going in to do that. So I'm sitting there, and a good way to help make sure you're not touching anything after you get sterile, lock your hands together like this, because they're right in front of your face and you know you're not going to touch anything. And so I sat there with my hands like this, walking, or I guess I stood there with staring at the wall as I listened to this awful scary movie. So like I said, do what you need to do to maintain that sterility, because it's important. Okay, so wound care. So most lacerations will do just fine if you kind of rinse it out, like slap some antibiotic ointment on it and cover it. Obviously, when we go through suturing and in your lab, they'll kind of talk through with you how to know when do we need to do more advanced therapies, but a lot of times that's enough. Adhesive skin tape is great for like superficial low tension wounds and to reinforce larger wounds after you close with sutures. These are kind of like your steri strips. Honestly, I'm not really sure how much they do. My experience is they often fall off quicker than we would like. Topical liquid skin adhesives are an awesome option just to create that barrier. Okay, so sutures. So these are used to approximate wound edges, and box 6-4 and box 6-5 goes through the different materials and techniques, okay? And it's also important to know which type of suture you have available to you. A lot of times it's 3-0. And if it's just a number alone, that indicates progressively larger suture sizes. So a 4 is bigger than a 1, and then numbers followed by a 0 indicate progressively smaller sutures. And then there's different types of needles according to the shape, like what they're kind of done to help to help close out. But a big part of suturing is knowing which wounds to suture and which ones not to. Okay, and so and it's also within a certain length of time that you can suture. Most of the time we want to get something, if it needs suturing, we want to have it closed by 18 hours after the incident. With facial wounds or wounds that are less likely to become infected, we can extend that out, but we do like it to be as close to, you know, the time of injury as possible. And speaking of facial wounds, I've said before that like I'm a firm believer in stay in your lane, and I will not suture somebody's facial wound because it's too much of a high cosmetic area. And I would want somebody that does it a lot more often than I do in order to close that, to minimize the risk of scarring. So oftentimes these people, if they have like a true wound that needs suturing, will actually go to plastics. And because you have more time, even up to 72 hours sometimes with facial wounds, it's easier to get people in for that. And then there's a whole bunch of basic suturing techniques based off of what type of wound you have, and they'll go through this more in your lab, okay? A couple of times that you also wouldn't want to suture: any dog or cat bite, okay? Anything that has, kind of those deep wounds, and that you're not sure if you can actually clean it out all the way. With just irrigation at the bedside, that would increase the risk of infection, okay? And then if you want to practice your suturing, when I learned to suture, we just had like raw chicken breasts, and you can order the suture kits online, and you can just like practice, like cut a hole in the chicken breast and then practice that. There's a lot like fancier ones that you can order just off of Amazon to help you as well. So the after suture care, this is a common abbreviation, is CDI, clean, dry, and intact, for how you say that wound is. It's also important to, monitor for signs of infection. And we often say that, like, all the time I go, if I take my toddler or something to the doctor and she has a cut or something, they're like, make sure you monitor for signs of infection, but nobody ever says what that actually is. And so then that's when you get into a lot of doctor Googling. And so you're looking for like warmth, redness, swelling, weird drainage, those kinds of things. Make sure you specifically outline it for your patients, because otherwise, just like, everybody else, they're like, look for this, but you don't really tell them what they're looking for. Suture removal, essentially, don't overthink it, okay? Like, if you can untie your shoes, you can take sutures out, okay? Your book goes through like, grab with your tweezers and pull up on one side, and then take your other thing and do this and all that. Essentially, you just need to elevate it enough to get your scissors under there, and make sure you don't pull the knot through the hole on the other side, because you don't want to do more damage. So you want to have it exit the skin without the knot traveling through the skin. Staples, they're finding, are pretty similar to sutures in the mechanical and histological characteristics, and staples seem to do better for contaminated wounds. A lot of surgeons use staples because it's faster. Also, they can decrease the inflammatory response, the wound width, wound closure times, and then it helps the edges of the wound evert to help with healing. Yeah, I feel like we're moving towards staples a lot more often. Joint aspiration and injection, most commonly used for diagnostic or therapeutic purposes. You would aspirate if you're looking for is there something abnormal actually in that fluid itself. Oftentimes the injections are used for, pain relief in arthritic or painful inflammatory conditions. Subungual hematoma drilling and drainage can usually happen about 36 hours after the injury, or after you realize that there's a hematoma. There's a bunch of different methods. One of them is, melting a small hole in the nail, which sounds completely awful to me, but I might use a different word than melting. That makes it sound a lot more painful, but there's a lot of different techniques that you can use for this, and most of them are pretty easy to go through. So they'll chat through that with you as well. Okay, so parenchyma is like tender inflamed infection of the hand or foot where the nail and skin meet. Normal people call this an ingrown toenail or an ingrown nail. Okay. It's a little bit poor terminology, because it can occur just because of, the way that the nails were trimmed, but it can also be bacterial, fungal, or viral. Sometimes it does require like, incision and drainage to help with that. A lot of times you can do like warm Epsom salt soaks and such to try to help bring the skin tissue back, as well as some like medications to help with those infections as well. Okay, so inserting IVs. IVs are great in that it allows injection of the drug directly into the vein. So it allows the fastest onset of medications. Okay, most of the time you guys would be using it is for rapid rehydration. And it can be really amazing how fast somebody can start feeling better with rapid rehydration. Okay. It's important to know your scope and wherever it is you're practicing, because it could be different based on if you're allowed to insert IVs or not. Okay. And the best thing you can do for yourself is to practice IV insertion. Fortunately, a good chunk of the people that you guys will be inserting on are, young, healthy athletes. So hopefully they have big garden hose veins. But sometimes when people are extra dehydrated, those veins will be smaller and it will be harder to get. So they'll walk you through the specific technique in order to insert these, okay? But a couple of things that weren't kind of mentioned here that I want to highlight is when you insert your IV, everybody seems to think that the needle stays in their skin, and it does not. Okay, so you'll see when you're working with the actual insertion needle that you retract the needle all the way, and the only thing that's left is the catheter. Okay, so that's an important thing to tell your patients. It's not like they're just walking around with a needle in them. Okay. Also, location is a good thing. If I put an IV in my arm right here, every time I bend my arm, I'm going to be kinking that off, and that will decrease how fast things can infuse. Then when you insert your IV, if you insert into the tissue instead of the vein, or if you blow all the way through the vein and you're infusing IV fluids really fast, they can get all of that fluid is going into the tissue and not into the vascular system. So the around it will really like swell up. And I believe they'll be going through that kind of stuff with you as well. Going back to aseptic technique, when you insert IV and then you get your tubing and you're actually attaching your tubing to the IV itself, current data says we need to scrub that hub for 30 seconds, which is a long time. Okay. I do a lot of the testing for the nursing students at Gonzaga, and I actually time them. And on average, if you're not thinking about it, people do about 6 seconds. Okay, this is again something that would be super policy oriented, but current data right now is showing we need to scrub that for 30 seconds in order to say that that is clean to attach our tubing to it. Okay. Like I said previously, if you ever have any questions after these, just let James know and he knows how to get in touch with me. And happy IV inserting.